Good afternoon, and welcome to this satellite webinar by GI Supply and hosted by ESGE. This webinar is aimed to comment different aspects of tattooing in colonoscopy, something that is part to the everyday activity in endoscopy units. We are going also to show the results of an expert consensus about tattooing in the colon, and we have today this agenda. First, we will have this introduction where I will explain the main characteristics of this consensus agreement. Then Professor Evelien Dekker from the AMC Hospital in Amsterdam, we will talk us about the endoscopic diagnosis of cancer and the application of tattooing when we have suspicion of a malignant polyp. Then Professor Sergio Alfieri from the Policlinica Gemelli in Rome will talk us about the importance of endoscopic tattooing for laparoscopic surgery, and then both together we will explain us the technique of tattooing. Finally, Cesare Hassan will talk us about the need of surveillance of advanced imaging for identifying recurrence and the role of tattooing in this scenario. Tattooing is an endoscopic technique that is used for facilitating future localization of lesions in the digestive tract. This is because the lack of landmarks in the colon. The colon only has two landmarks, the ileocecal valve and the anus, and in between there is a field where we don't have any reference for localizing the majority of lesions. That results in large differences between location of colonic lesions reported by endoscopies and real location. That's something that we are familiar with, and this is an everyday discussion with our surgeons. And moreover, there is a lack of clinical studies aimed to establish indications and methodology of tattooing, and that results in a highly variable technique and practice of tattooing. For this reason, our aim was to establish a consensus on indication and appropriate techniques for colonic tattoo placement. And we said that in three domains. First, we discussed about when tattooing should not be used, which are the exceptions for the use of tattooing. Secondly, we also talked about the indications for tattooing, differentiating for different scenarios. First, in case of deep invasive cancer. Second, in case of superficial neoplasia at risk of submucosal invasion after resection. Third, in neoplasia that is referred for resection at a subsequent colonoscopy. And finally, in the wall of surveillance of the polypectomy scar. And finally, our third domain was statements about the technique of tattooing. We did this consensus based on a Delphi process with initially 46 statements, with an experts panel with 29 international experts from Europe, the US, and Asia Pacific area, and 5 experts in abdominal surgery for specific questions. And we used 3 voting rounds. In these voting rounds, we finally obtained 15 statements that we are going to discuss now. These indications for tattooing are, as I said, for endoscopic diagnosis of deep invasive cancer, and here the tattooing is for surgical resection. When there is an endoscopic resection of a lesion with suspicion of submucosal invasion, the tattooing is for, there are 2 possibilities for possible surgical resection and also for surveillance in case the endoscopic resection has been successful. When there are lesions difficult to detect but are left in situ for future endoscopic resection, the tattooing is made is made for helping in future endoscopic resection. And finally, with polyps, with large polyps with additional predictors of recurrence, the indication of the intention of tattooing is surveillance. First, Professor Evelien Dekker from Amsterdam will talk out us about the endoscopic diagnosis of cancer and its application on tattooing.
Rodrigo, hello. Good evening to everyone. Great presentation on the Delphi process. Before Evelien starts her presentation, I want to ask to Sergio Alfieri, who is the Italian surgeon with the largest volume of colorectal surgery. How often, Sergio, are you happy with what we as endoscopists do when we send a deep invasive cancer to you about tattoo? And how often are you unhappy because the endoscopist didn't do the appropriate tattoo and maybe you need to do a second endoscopy? Is it improving in the last 10 years in your experience?
Good evening to everybody. I'm Sergio Alfieri from Rome, Italy. Okay, very clear the question. You know, it depends because I make operation of patients that receive a colonoscopy by different endoscopies. So I'm always happy if the tattoo is well done. And then probably in the next 1 hour, we will see what does it mean. I'm unhappy if tattoo can give me more problem to identify the lesions, or maybe if there is too much tattoo, or maybe if I can find, or if there is no tattoo when I need. So I don't want to tell everything now, but I am always happy if tattoo is well performed in the right position, because always help us. And I also to tell you that in the last 2 or 3 years is improved the knowledge from the endoscopy side of the importance of tattoo, because many times, especially in the laparoscopic procedure, we can find problem to discover small lesion and not, of course, a big cancer. So I found a lot of improved by endoscopy's part, but in the same time, not always well done.
This is the reason for this webinar, or for this Delphi agreement also, to avoid the variability between practice between gastroenterologists, and to help surgeons and other endoscopists to do adequately the tattooing. Let's go with Evelien.
Hello, my name is Evelien Dekker from Amsterdam. Indeed, the topic of my talk is how to recognize early invasive lesions. And that's indeed a challenge, because if we would like optimal effectiveness of colonoscopy, we would like not only to detect all possible pre-malignant lesions during colonoscopy, but also make an accurate optical diagnosis. Because in the end, we only want to resect lesions endoscopically that we think we can cure by doing so. So we do need to resect them completely, and also be able to deliver the appropriate specimen to the pathologist. And if not so, we should refer either to another endoscopist or to a surgeon. So how about radical resection of T1 colorectal cancers? Well, that depends on several different aspects. First of all, of course, the lesion has to be taken out, and we have to look very well at the depth of submucosal invasion. And that can be SM1, SM2, or SM3, depending on the numbers of millimeters assessed. There might be lymphangial invasion. There might be tumor differentiation, which if badly differentiated, that's bad for prognostic value, tumor budding, and maybe more in future. There's still research going on. And that's all important, because if all the last ones being named, if they're all positives, that means there's no lymphangial invasion, no tumor differentiation, no tumor budding, still an SM3 might be cured by taking the lesion out endoscopically, because the chance of positive lymph nodes locally is probably very low.
Evelien,
yes,
I promise to behave properly, but this comes quite new. to me and maybe to the audience. We learned that only SM1 can be considered a low-risk superficial cancer. But now you are teaching us that even SM2 and SM3 can be considered
Yes.
low risk. Is this something that we need to apply immediately in our practice, or is it for expert center like your center?
You're very awake. This is indeed relatively new. Maybe I'm a bit too early in stating so, but it looks at the moment as if the lesions that only present deep mucosal invasion but are still taken out radically without any of the other bad prognostic factors might result in a very low recurrence rate. But I agree with you, it's relatively new and data are still accumulating. Actually, we are currently looking at all the data and performing a meta-analysis. So don't do that because you usually do many of those meta-analysis. We are working on that. And I think, you know, the evidence will probably get there. But the thing is that we can only tell for sure if we have an appropriate specimen. And of course, very often that's not the case because it's not taken out appropriately to deliver the specimen to the pathologist. And
I just say, Evelien, that this is extremely important, a step ahead for our specialty. So I just thank you for this contribution.
So I totally agree, but it means that we have to be able to tell ourselves that it is invasive at the moment we scope the patient. And we know we as endoscopists have still a problem there and we should do better. So we wrote with a group of Europeans the ESGE guideline for advanced imaging on detection and differentiation of colorectal neoplasia. And of course, now we are focusing on characterization, and the advice for whatever lesion you detect is to use your virtual chromoendoscopy. That's almost at the moment on all endoscopes, and if not so, please use your conventional chromo, but at least high definition. Well, we then have the QDOT pit pattern to look at what kind of lesion we are seeing in the colon. And if you look to the right, we should be able to discriminate the type 5, which is usually, when using the QDOT pit pattern, the very invasive cancer, which is usually deeply invasive. But we can only see such an invasive part if we're looking very well at the lesion. And here we are seeing a very nice granular, laterally spreading tumor in the cecum that was referred to us. And we thought, well, this looks like a very nice polyp to remove endoscopically. Nice work to do, we are happy. But then look, if we start to inspect further, we can do that very nicely when using, in this case, NBI, but BLI, whatever you use is fine. And also I'm using here a plastic transparent cap on the tip of the endoscope because it usually makes you more easy to look behind folds because you can look very well at the surface without having a red out. And what you can see here is definitely a very suspicious area that's just right behind the ileocecal valve. And look here, even with high definition white light, I think it's very clear we're seeing here a deeply invasive cancer that we should absolutely not try to remove endoscopically. This is another example, I think, very nice. Also a referred patient to us to take out a lesion endoscopically. But here again, if you look up behind the fold, you can see the invasive part. And this is a very nasty polyp that we should not take out. So indeed, we should try with a new nice classification to make the distinction between 2 and 3. Another way of looking at the classification, but still nice 3, is deep invasive. And that's clear. We shouldn't take those lesions out. But how about those lesions that are in between those two typical types of adenoma and deeply invasive cancer? Well, the Japanese have taught us a lot. They're really in optical diagnosis ahead of us, and they're using very nice endoscopes, but besides that, very often zoom as well as additional chromo. But look here at the different types with the digital chromoendoscopy, and you can see that they made up special types, which is the type 2B in the JNet classification, which is the type of lesion that is just the focus of still optimal endoscopic resection, because those are the lesions that are, as you can see here, high-grade intramucosal neoplasia, which means high-grade dysplasia in the Western world, or superficial submucosal invasive cancer, which is also high-grade dysplasia in our world, because in the Western world we still call it high-grade dysplasia if it's not invading the submucosa, but here if it's just invading, it's an SM1, and that should still for sure be endoscopically resectable. So this is the group that we would like to look at further. Is it that easy? Well, maybe not even for the Japanese at this stage. Look how they use it. They use it very nice, but they also use additional special chromo like Brazil violet here. And they also always use the magnifying chromo, which is not really daily use in the Western world. However, you can also see here that they do quite well, but not always so well. If you look, for example, at the type 2B, I told you these are the lesions that are just invasive or still high-grade dysplasia. They don't do all that well because there's quite a lot of low-grade dysplasias in that group, but also deeply invasive cancer in the group. So they don't do perfect either, and they are again ahead of us. So we still have a challenge there to go. And with the ESGE, we are currently performing a prospective study together with the Japanese, trying to validate the use of JNET in the Western world. Is there other features of cancer? Yes, there is, because most of those lesions are friable, indurated, ulcerated, excavated, where you can see the fold convergence, and that's quite often a malignant feature, and also the non-lifting sign that you might recognize here. Well, although we know this, still we run into a lot of unexpected cancers in daily practice. And this is just an example that we recently published on the Dutch National Bowel Cancer Screening Program using FIT, where indeed we select for high-risk patients with a lot of T1 cancers. And you can see here at an analysis that of the 92 early cases in the program, only 39 were endoscopically indeed recognized as being a cancer. And all the other ones were what we call oops cancers, which meant that the endoscopist only heard so afterwards by the pathologist. And you might definitely miss the chance in those cases to treat the patient with minimal invasive therapy radically. Also in the trend study, that's already some older data where we removed large rectal lesions endoscopically versus surgically. Only benign lesions were to be included, and even advanced imaging could be used, and also radiologic imaging. But still, despite that allowance, 13% of all the rectal LSTs were wrongly diagnosed as being benign, but appeared invasive after all. So we do have a problem. We know that also from the Australian group, where they only included lesions that looked endoscopically benign. And if you just have a look at the morphology of the lesions as well as the location, you can see that also predicts the unrecognizable cancers. So for example, in the distal colon, when you see a non-granular lesion like this one, or a non-granular lesion with an extrasessile part, you can see that the risk in the rectum of this lesion, although you don't see the invasive part, is still around 16%, and here even 21% of the lesion being invasive, deeply invasive anyhow. So we need to do better, and maybe combining both the endoscopic mucosal pattern as well as those, for example, morphological features might do better, and still research is on its way here. So I have a few examples just to illustrate the difficulty, and maybe one of the other panel members would like to comment. So I can see here endoscopic.
Yeah, let's try.
Yeah, you will try? Yeah, I knew you would take the challenge, but you haven't had a look at the slide yet, have you? So
no, not time, Evelien.
Okay. Well, this is the lesion. This is a very interesting lesion, right? It looks with a little bit indurated in the middle, a little bit excavated. You can see here still, I would say probably a Cudo 4, but what is here? Is this a JNET 2B maybe? Not so easy. We're using MBI and near focus, but I will show you a few more pictures and then you may decide. This is from a little bit further, and now I come up close again. So what is your guess?
Okay, so when you look in a fit positive at this lesion with this depression, I mean, you immediately think about a cancer, a deep cancer. But I must admit that, of course, you are rich, you have the near focus and the NBI, and I must admit that it's not completely destructured at the center. It's not pit pattern 5 non-structured. So despite my initial guess was deep invasive cancer, now I must admit that you create some doubt to me that this could be resectable.
So what would be your endoscopic technique then here?
I mean, I don't, I'm not at AMC, so I would try just to lift also because it is, I mean, it doesn't appear to me as a big lesion. So the problem is not for me to snare this. The problem is the natural history. Of course, I'm never happy when I resect deep invasive cancer and then I call Sergio as a backup. I prefer to send to Sergio the cancer virgin. But Evelien, you create me some difficulty with this near focus because I'm not confident that there is the structuring in the center. So probably I would try to have a removal. So.
Okay, so the next one is for Rodrigo, right? I see him, he wants to comment, but maybe Rodrigo does the next case, okay? So here it is. We saw the 12 millimeter lesion, the Paris 2A with the central depression, QDO 5, not total loss. So I had a difficulty with JNet, probably 2B. So we thought, well, probably it's an adenoma with high-grade dysplasia or early invasive, but we indeed didn't like the excavation either. So what we decided is to perform an endoscopic full-thickness resection. I don't have slides of how to do that because that's not really the focus of this talk, but the big advantage is that you take, you make sure you have a perfect histopathology specimen because you take the lesion out with all the other the full thickness of the colon wall, so we can have a definite decision by the pathologist on the invasiveness of the lesion. So this is what happens. This is the lesion. It's really not very big, as you can see, and on the right side you can see the lesion after being resected, where we take the full thickness but already put a huge clip. And you can see that with the 4 ears on the right side. So you close the perforation before making it by taking out the whole lesion in all its depth. So then we send the lesion for...
Sorry, what was the location?
It was rather proximal. I think it was the ascending, but I have to, but it was not distal for sure. Yeah.
Okay, now this is important because maybe in fit positive, the slide by Mike Burke that you showed can be not fully applicable. I mean, this lesion, even in the proximal colon, may be actually more advanced than expected. That's stupid talk.
Yeah,
okay.
But the advantage of this technique is that you will know for sure after your resection, right? You don't compromise the pathology specimen, so you will know for sure whether you need to advance to more invasive surgery after all.
The question here is that only small lesions are available for this technique. If the lesions were large, maybe submucosal dissection or could be good for that kind of lesion with this.
Absolutely. So decision making would have been more difficult if the lesion would have been suspicious and advanced in the right-sided colon. I agree, if it would have been larger. But for small lesions, this is a perfect technique to have optimal pathology. Yeah.
That should be tattooed.
And then, indeed, the tattoo is extremely important because we need to know exactly where this was in case we decide to send the patient to surgery because of bad prognostic features of a possible cancer, right? So this is the histopathology. And this is indeed an SM3 with only as a bad prognostic factor the deep invasiveness, the SM3, not being a T2, but SM3 T1. But the lesion was well differentiated, no lymphangial invasion, no tumor budding, and it was free, the margins both horizontal and vertical. So we, in this case, And I'm not sure what you would decide, Cesare, but we decided to perform surveillance only in this patient.
Evelien,
very important, Evelien, because if I read SM3, I would have called Sergio. This doesn't mean that Sergio would proceed on operating, because I guess that Sergio does a multidisciplinary approach, calculating mortality and blah, blah, blah. But for me, I would have called Sergio also for medical legal issues. Sergio, I don't know if you always operate this patient or not.
No, I agree with surveillance, but I want to ask to Evelien if in this case she performed the tattoo or not.
Yes, of course, like I discussed, we need to, yes.
Okay, it's important to underline that we know the histopathological report maybe 2, 3, 4, 7 days after your procedure, so it's very important to tattoo before the histopathological.
I agree.
Absolutely.
We are talking about the importance of when, how, and where to tattoo, to underline that in this.
But we will come to that later. That was indeed not the topic of my talk. But
no, I know, absolutely. But as we are talking about tattoo, in the specific case, we decide to surveillance. So maybe we have to underline that, especially in this case, it's very important to make a tattoo because histological report.
But Sergio, the tattoo was only in case I would have referred the patient for surgery because of any bad prognostic factors. Because in this case, the recurrence will not be in the resection margins, right? The lesion was totally taken out.
I agree.
So it will be more distant.
I agree with you, but as we know, only after maybe 6, 7 days, it depends on different hospital, if you have to send the patient to the surgeon or not.
Absolutely.
If you don't tattoo, then could happen sometimes, just to tell the audience, other colleagues that are with us, that sometimes it's happened that you need a second colonoscopy because you didn't perform a tattoo, because you thought during your colonoscopy that you would be.
Absolutely.
Okay, so we agree, just to underline. Thank you, Evelien.
This is one of the statements we will talk about, in which cases we will do tattooing in a case like that. It is always that the statement, but please, we should move forward because we are...
we have to move a little bit quicker. So this was another patient, 75 years old, who was FIT positive. This was the lesion we saw already using MBI, and again using the cap, where you can see quite nasty lesion. That's also a bit slimy. You can't see the whole pit pattern, I think, accurately, but your attention is drawn to the middle, right? I think to this. So this looks like a serrated part with all the slime and the open crypts here. It's cloudy. It's difficult to define, but here this looks different, definitely from that side. So we have more slides here, same image, and one here. So what is your guess, Cesare? Or Rodrigo, maybe now.
These are very difficult lesions.
Looks like an invasive cancer in that part.
I mean, I agree with Evelien that most is serrated, but
Okay, so you think it's suspicious, right? We thought this we don't see well, but this looks absolutely strange. So we say malignant focus, that's what we think, okay? That's not the diagnosis because this was before endoscopic resection. So what would be your, I will continue. This was in the cecum. It was non-stenosing, about 15 millimeters, Paris 2A with central depression also here, and QDO5. And we thought, well, there might be an invasive cancer in that area, right? That looked very funny with the dark, irregular vascular pattern there. So we thought, well, this will probably just fit in another cap. So it's a very popular treatment method at the moment in my center. It's easy and quick, the full thickness, as long as, like Rodrigo said, the lesion is not too large. And on the right side, you might even be able to resect a 20 millimeter lesion, but 15, especially on the left side, is about the official maximum. So we do that here. We mark the lesion before pulling the lesion into the cap and resecting it. And here you can see the resection specimen. So it looks endoscopically nice radical. You can see it here after being taken out and put on the on the mat with MBI. And this is why I say we have a perfect pathology specimen, because the pathologist really has all the different layers of the colonic wall. And what he sees here is he sees a sessile serrated lesion with indeed high-grade dysplasia, but no invasive cancer, not anywhere in those lines. It had been taken out radically. It had free margins, distance 0.6 centimeters, so very radical. So we also in this case decided for surveillance.
Yeah, I fully agree with you. I mean, this is a fully agreeable strategy. If I did an EMR, piecemeal EMR, would have this been a bad treatment in your view? Maybe you can go back to the lesion.
You know what, Cesare? No. Afterwards, we could decide now, no, but it might, there's several things. One is that ideally you would take this lesion in one piece, right? In one single piece. Maybe you are able to do that in this case, but it's, I think, a relatively large lesion to lift and resect in one single piece in the right-sided colon. So that's one. Then two is, if you don't, at least look very well in how you're going to take your specimen, right? So if you say, well, I think this is a very suspicious area, I would probably then do this and take this. But my main message is you should be very warned here. And although we ended up with high-grade dysplasia, this might also have been an early cancer. And this is exactly where also JNET falls short, I think. And then I would prefer a single piece resection. But if not possible, think smart and try to take the worst lesion or the worst part in one single piece and ask the pathologist, probably put it in a separate jar and ask the pathologist about that. The thing is, if he's in doubt, if he doesn't have it in a nice direction and he can't see the margins, he might even not be able to tell you it's only high-grade dysplasia, and he might worry it is submucosally invasive, and then you might end up to do surgery anyhow. So, and tattooing again, Sergio, of course, here as well. So last, very quick one. This one was also, I think, a very funny lesion. Looks very odd, eh?
Me, Evelien.
You were saying this before, you don't like this.
Focus. Yeah, for me, this is the structure.
Yeah, I also don't like this at all. Looks very odd. It was a bit larger in the rectus sigmoid, about 20 centimeters from the anal verge. Well, it was not so easy to look very well at the pit pattern here, but we thought there was a JNET at least 2B, maybe even 3. So we thought, well, this must be a T1 cancer. We don't want to lose the opportunity to resect it endoscopically. It was quite large, so we decided performing an ESD. Actually, my colleague, Barbara Bastiaanse, did this, who was very helpful with providing me with those slides together with Lieselot Zwager. So this was the case. This is what she did. She took out the lesion by ESD very nicely, as you can see here, going between the layers. And this is the end result, which I think looks perfect. As you know, this is a technique that's quite high demanding of the endoscopist. It definitely needs somebody with expertise. This is what it looks like in the end. But look, was it all worthwhile? This was just a high-grade dysplastic adenoma. However, we know for sure now it was radically taken out, intact and complete. So at least we don't need to do appropriate surveillance.
This is a male patient. The previous one was a female.
Yeah.
This is a different patient.
Absolutely. Oh, sorry. It is the same patient.
Ah, okay.
You're too attentive. This is the same one. For sure. This was really high-grade dysplasia. We were all very surprised as well. Don't worry.
Evelien, are you meaning with your examples that we should almost always try?
No, I mean with my examples, I have the main messages here, but what I mean is that it's challenging. Look at the first one, crucial for decision making, but challenging. And we need to always think about it when, even for small polyps, but also when you inspect a large lesion, don't just start taking it out, but look at it very well first. And well, you can try, but make sure you provide the best possible pathology specimen to your pathologist if you think it might be early cancer. And if you're not going to be able to do that, please refer to somebody who would be able to do that, because you don't want to miss the opportunity to for non-invasive treatment.
Absolutely agree, because sometimes the only reference we have is the surgeon. We have to be prepared to be also the reference, or to have someone of reference for referring that kind of lesions.
So I would like to finish due to time, because otherwise we won't have time for the next topic. So please go ahead, Rodrigo.
These are the statements related to the topic Evelien have nicely addressed. The first statement about this topic is that tattooing should always be used after endoscopic resection of a lesion with suspicion of submucosal invasion. You agree, Evelien? Do you think that should be used always, with the exception of the cecum and the rectum that we will talk about later? Do you think that should be used always when
yes,
there is suspicion of submucosal invasion?
Yes, like you say, there is absolutely exceptions. If you are in the cecum and you can very well see the ileocecal valve, I think it doesn't make sense. I would try to make an image of your lesion together with the cecal landmarks. And in the rectum, there's also exceptions definitely there. But in general, yes. And it's something people tend to forget. So like Sergio already said, highlighted, I think, please don't forget, you're totally occupied by making the diagnosis and you're worried and you start thinking, what should we do? But don't forget to put the tattoo. Yeah.
The other statement is that for a colorectal lesion that is left in situ, but considered suitable for subsequent endoscopic resection, this is the lesion that we refer to another colleague, that we refer to ourselves when we will be more relaxed and we have time for doing that. Tattooing may be used if the lesion is considered difficult to detect in future endoscopy. Not always, but only if the lesion is considered difficult to detect in future endoscopy. Any comment, Evelien?
Yes, I'm definitely in favor to only do this in this indication and not always, because there are several reasons for that. I think first, we don't want too many tattoos in the colon, because then we don't know which tattoo is for what reason. And if we need a surgical resection later and we need another tattoo, we have to make sure the surgeon knows which tattoo is which. But also because quite often the tattoo runs a little bit into the lesion. And that's, I think, for the advanced endoscopist, the biggest worry, because it will make endoscopic resection more difficult, radical resection. So there's several reasons not to tattoo every lesion that you detect.
Thank you, Evelien. I think you have nicely defined the reasons for not to abuse of tattooing. The tattooing should be used also with prudence, only in cases that is indicated, because we can fill the colon of tattooing and not doing anything.
Rodrigo, I want to make a question to Sergio to underline the importance of tattoo for suspected submucosal cancer. Sergio, are you there?
Yes, yes, I'm here.
Okay, so Sergio, imagine that I remove a small pedunculated polyp in the descending colon at 40 centimeters from anal margin. I forget to do the tattoo, but then high risk invasive cancer come. I cannot find the scar because it was a small pedunculated polyp, and so I send it to you. I tell Sergio, this is high risk cancer in the descending colon, 40 centimeters. but I cannot find the scar and I forgot to tattoo. How much this complicate your surgical approach? Because I guess this is at the end the crux of the problem.
So Cesare, first things I'll call you and I kill you. First thing, because you forgot. This is a big problem for different reasons. First, the 40 centimeter from the anal verge is different between, now we have 306 colleagues from all over the world that are in our webinar, and your 40 centimeter is different of mine, of other colleagues, because you know better than me than 40 can become 60 or 20, depending for many reasons, first. And like you, people that go fishing, you know, they say that they take a very big fish and you never know how big is it, or maybe they never. So if it is a small polyp, you can't find the scar or the clips. If you put the clips or something like that, really you don't know what to do, because the 40 centimeter, they really could become 20 or 60. And you can't to consider a small, big, resection to the patient. So it's also depending from the age. In this case, I will not operate the patients. I mean, if I also to this, if I have to decide only by histological report, I say no, it's not enough. I can't, because maybe I do a left hemicolectomy and it's not enough, because I should go a little bit deeper in the pelvis or a little bit higher in the colon transverse. So if I have a CT scan or something like difference that suggests me to make operation, but it's very difficult, like liver mets or lymph nodes. But in this case, I do not make operation, because it should be very easy. I say, okay, go in 40 centimeter and make a tattoo. Even if you can do blind, you can do that. But as we know that 40 centimeter is very dependent from the endoscopy, I will say, no, do not operate. We have to wait, make a follow-up, and we will see what's happened.
Okay,
and of course, this is a big problem, because the responsibility is of the endoscopists that didn't make the tattoo. So my suggestion, especially for small lesion, because if you have a big lesion, it's easier to find also after another endoscopy if you forgot. But if you have a small lesion, especially in that lesion that you think that is benign, make a little tattoo. Doesn't cost anything.
Yeah.
This is the reason we have to make that kind of agreements. But sometimes this is an scenario that is awful, but sometimes that happens. So the message that we have to pay attention of the characteristic of the polyps before deciding. Let's move forward, because we are a little bit delayed. Next speaker is Sergio Alfieri from the Policlinico Gemelli about the importance of endoscopic tattooing for laparoscopic surgery.
Okay, here we are. So I'll try to show you some cases that happens in my daily practice. And first thing, you make you say, okay, I do not forget to make a tattoo, but you did the tattoo. So the important for the surgeon then is to find the tattoo, even if you did it during your endoscopy, and to find the tattoo. That means find the small lesion if they were resected during endoscopy, or you can make operation in people that are very fat, so have a big omentum that cover the colon. There are many, it could happen many difficult during surgery, especially in no thin people. So it's very important for us that have tattoo placed as you can read here, in the circumference, and not only in one side, and not tattoo placed only on the mesocolic and mesorectum or retroperitoneal side are difficult to visualize, especially in fat people. I'll show you some surgery. This is the sigma, and here is the pelvis. Here we have the head and the foot. You see, in this case, there is a cancer. I have a tattoo, but up to now I can't find any tattoo, and so I do not know where to resect, and so I have to open posteriorly the mesorectum, because as you will see in few seconds, we have the tattoo only in the posterior part, and Okay, you see, in this case, now that I open the mesorectum, I can find the tattoo. And it is not very good because as in this case, it was performed distally, as it was right from the lesions, maybe I could perform a less extensive surgery if you did, or if the colleague did, the tattoo also anteriorly, that where there is not the fat. You see, and how much tattoo we have in this rectum. And this is the specimen, and then you see the tattoo here that was only posteriorly that I could discover only when I opened the mesorectum. In this case, you could see actually also the tumor because it's present also anteriorly. And when we open the specimen, we have here the cancer, and here we have the tattoo that is done in the correct form, but only posteriorly. That is not easy to the surgeon to discover. In this case, we have, you see that again, here we have the foot, here the head, this is the pelvis, the sigma, and then the rectum. We didn't open the pelvis, still open the pelvis. You see the tattoo is here. It's very correct, you're right, but in this case, the endoscopist did two tattoos, one anteriorly, one posteriorly, one proximal, and one distally. And that is not very good, because if I don't be sure, and if I don't read very well the endoscopy report, and I read that he did the two tattoos, one proximal and one distal, we have the tumor. I could think that maybe this could be the distal tattoo of the lesion, and so maybe it could happen, not of course in this case we are lucky not, to cut here and to leave the tumor. So we have to agree if perform one tattoo and cranially, caudally, because if I think that we have only one tattoo, I could cut here and leave the tumor. As I read very well the tattoo, I have one distally, and so this is a robotic resection. And once that I open again the pelvis, and I could find the distally part of the tattoo, and then we cut here, as you see here, and then make a resection, as you see here. And you see the specimen with the cancer, the proximal, and the distal tattoo. Imagine if I cut here just in the proximal part and leave the scar of the cancer here. So it's very important.
I think this is one of the most important message for our audience. Can we agree that a double tattoo for one single lesion should never ever done? Because I guess that any of us had terrible cases when two tattoos were done and then not proper surgery were done. So do you agree also, Evelien and Rodrigo, that two tattoos, one proximal, one anal, should never ever be done for one lesion?
It is indicated to make 2 or 3 tattoos, but all of them in the same direction, especially anal or distal to the lesion. In case of surgery, there is a statement about that. In case of referral for surgery, more than one tattoo should be applied, because as Sergio explained nicely, it is important for seeing the tattoo in each location, but all the tattoos never in both sides of the lesion, always distal to the lesion or anal.
Exactly.
Go ahead, Sergio.
Yes, exactly, especially for the rectal left side. We will see later that maybe there is something in some cases for transverse column, but we will talk a little bit later. And also because you have to think that as you are a lot of the endoscopists, you can find a lot of surgeons, and they are not all skilled as you could have in your hospital. So they could, in this case, be confused and cut in the first tattoo. Let's go over. And so this other case, again, you see this is the aorta, and again we have here the rectum. You see the cancer, and you see here proximal the tumor, and this is the tumor that was very evident. And again, another cases that we have the tattoo distally. So we said that we agree that there is not indication, especially for the left column, for the rectum, and I can tell you also for the right side of the column. The best plane of injection, you mean to prevent dye infiltration of the muscular propria, or a transdermal injection, and which leads to diffuse staining in the spillage into the peritoneum. You will see what could happen sometimes, what we can find, and to reduce the incidence of localizations mistakes, and avoid acute symptoms of adhesions formation, colonic abscess, focal peritonitis, and fat necrosis. We think that, but you are the best than me, the teacher of that, that's because maybe it's better. Because as you see in this case, if you start an operation, like in this case, and you see all the tattoo in the fat, in the mesorectum, in the mesopelvis, and this is the right side where you should not any indication, especially for the cecum localization to tattoo. You did a lot of tattoo, you can find everywhere, and also in the duodenum, in the peritoneum, and in this case you really don't need the tattoo because in the cecum localization you have not to mistake, and this colleague make a lot of tattoo. We found tattoo, you know, everywhere, and so sometimes few, sometimes a lot. Or like in this other case, this is a pelvis again, and in the tattoo, the posterior part, and you will see, as we can find also in this case, tattoo for more than 10 centimeters, so you don't know where to cut when you do too much, you know, and all around. So
Sergio, I feel that this point is extremely important because up to now we considered the bleb something to help the endoscopist to minimize the pain of the procedure and blah, blah, blah. But now you show the surgical side. To do the bleb is extremely important not to mess up the surgical plan. So again, your contribution is excellent because you show to us the other side. That is equally, if not more important than the endoscopic one. So the message is very well taken. Thanks.
And this is another case, as you see. You can see how many tattoo we have around, and this is the specimen, and sometimes you can arrive to resect very close to the cancer, because when you have a lot of tattoo, you know where to cut. In this case, the patient need during operation to recut again, because when we opened the specimen, we saw that the tumor was very close to the specimen, for the reason that we said, because you see how the tattoo was in this case also a lot, you know where to cut. So for bigger lesion, you can see the lesion, but in this other case, if you have a lot of tattoo, you can really make you confusion where to do that. You see how many tattoo was in this case.
Very convincing, Sergio. This is very educational.
Okay. In this case, you see again that the tattoo was arrived to the splenic flexure, but was the tumor was not in the splenic flexure. You see all the tattoo in the omentum, how much tattoo was in the peritoneum. And I have cases, patients that was referred to me from many endoscopists, not just from one. Otherwise could tell him, please, why don't you do less, or you do better. So to underline that this is a problem, this is why we are here tonight, because I think that if my endoscopist that refer me to patient have this probably also it's a problem in your country, I think. Okay, thank you.
We agree. Let's move on because we are tight with the time.
Next
Rodrigo,
statement, as Sergio has
before
explained,
you continue, let me state.
I'm going to continue.
Yes.
As Sergio explained, tattooing should be used in case of endoscopic diagnosis of deep invasive cancer. That is necessary, and Sergio has explained us that very nicely. Go ahead. Next talk
let me just say for the audience, because some came later, that this Delphi process came from an independent group, not directly from the ESGE. It has been participated by the most authoritative endoscopists in the world. So it will come under publication quite soon. So please move on with the how to tattoo. I feel everyone is very interested in this. How to tattoo.
Yes, I think that the reason becomes clear when seeing all the examples of the surgeon. So we definitely need to make sure we have an appropriate protocol. So the indications is first. Well, I think there's the, as we discussed already, the endoscopic diagnosis of deep invasive cancer. That's for surgery, right? Then if you detect and resect a lesion with the suspicion of submucosal invasion, we discussed that, either for re-inspection of the resection margin or for the surgeon, if you find out it has too many risk factors. The neoplasia to be resected at next colonoscopy, as Rodrigo said, but only if considered difficult to detect. Then after polyp resection for surveillance of the scar, I would do that only for piecemeal polypectomy over 20 millimeters or additional risk factors. And then last but not least, that was not in the guideline, and this is an extra from me because my video will show such a patient. I see many patients with adenomatous or serrated polyposis syndromes or even other polyposis syndromes. And then we often decide where to resect this, the plane for subtotal colectomy. So we then intend to have a rectosigmoidal resection plane, and we want to resect all the polyps distal from that and ask the surgeon to perform a colectomy of the upper part. So that's another indication, again, not in our consensus paper. Where not to tattoo, we said there were some examples. Well, there's the cecum with the clear landmarks. I told you I would make an image of the lesion, including the landmark. So there's no doubt that you know exactly where the lesion is. And then in general, not in the rectum, because we can measure the length for the lesion from the anal verge. And we have concerns there, like mesorectal spilling, making it more difficult to resect that part, or dispersion of the tattoo. So the number of tattoos for surgery, as discussed already, always 3 in a circular fashion to prevent the location just at the mesentery. I think nicely illustrated by our surgeon. For a next endoscopy, so in case of redetecting a difficult lesion for surveillance, 1 tattoo should be sufficient. Always then 3 to 5 centimeters distal, so the anal side from the lesion. If we do that all the same way, there's never any doubt and any confusion about that. For surgery, again, circumferentially 3 tattoos, and for a next endoscopy, just 1. And then it's really important to avoid too close injection and ink under the lesion, as I already mentioned. So this is an example of the technique. Again, in a patient that I saw with many polyps. We are starting the tattooing here. And what you do is you define the location, you load the needle with saline, and you start making 3 small blebs. You see a polyp there up front, that's not a bleb yet. But here you will see the second small injection. We make small blebs. Just as soon as you see the submucosal space being injected, you stop. No more than that, but avoid trying to inject too deep, because if you make a leak to the peritoneal cavity, you can make a problem with leaking the ink into the peritoneal cavity. So we make 3 small blebs in this case because it's for surgical indication. So again, a very small bleb and stop. Okay, so we have 3 small blebs now circumferentially. What we will do now is we load the needle and the length of the needle with the ink, the tattoo ink. And we do that with approximately 2 mLs, because I know it's going to be about 2 ml to fill the whole needle. And then you can see here, I asked the nurse to very gently inject the ink usually just half an ml when I'm in the lesion and no more, because we don't want the huge tattoos. Then this last one didn't go as nice, and I think I would just leave it in because it's a nice example that it's not always that easy to place your ink in the right direction. This was a nice bleb, but I don't succeed. And this, look at this one. This is not a submucosal bleb. This is an intramucosal bleb. And as soon as it tears, the whole bleb will be gone. So there might still be some tattoo in the submucosa because I injected it before, but the last one is not a good example. What I recommend afterwards is make an image after rinsing for your surgeon and to prove that you did do the tattooing.
Evelien, how much spot X did you inject in any bleb?
About half an ml, no more. I don't want huge blebs, and you already have put in some saline. Please don't do more than that, because we don't want huge ink blebs that spread out the whole colon, right? So here it is. We already discussed it. I think that's clear. So for documentation, report exactly the intention of the tattoo. Why did you tattoo? The location. So there will be no doubt afterwards. So if the surgeon operates, he can read back which column segment into relation to which, and also the number of tattoos. And I always also like to tell my patient he has a tattoo. So my special remarks would be, make sure you have a clear protocol in your institution. So everybody does it the same way. So there will be no confusion with the surgeon. Do not omit the saline blebs, even if you are a very experienced endoscopist, because even so often you will either be too superficial or too deep and inject into the peritoneal cavity. You've seen the results from our surgeon. Experience yourself in the injection. I always tell my fellows that you have to do it like darting. So the short, quick darting action to try to be in the middle of the submucosa. And if you do it too slowly, you might not reach the submucosa or go through it and be directly intraperitoneal. Try to make the blebs as small as possible. I told you, because they will divide anyways. Try to avoid too much spill of ink, and try not to over tattoo, like you asked already, Cesare. Not too much ink. There's no use for that, and there's only disadvantages. And also, we don't need to place too many tattoos or to tattoo anything we see, like we said, because maybe in future the patient might need more. That's it from my side.
Very convincing, Evelien. Maybe Sergio, we need to skip to the last part on recurrence, because we are quite in delay, but all these topics are so important and the audience has been
okay, so absolutely, yes, no problem.
Okay,
just
can we move forward,
remarking the statements.
Okay.
The first exceptions, tattooing should not be used in the cecum, and in general not in the rectum. Next slide, please. A saline bleb in the submucosal layer should be created before tattooing. For the localization, it's very important, as Sergio explained, to be placed 3 to 5 centimeters, not too close to the lesion, in the anal side of the lesion. And for localization of lesion referred for surgery, 2 or 3 tattoos should be placed circumferentially. Regarding the technique, a tattoo should never be injected directly into or underneath the lesion. That might be endoscopically removable at the point because of the potential of creating fibrosis. And for the localization of polyps or scars, in general, only 1 tattoo is needed, and the volume should be enough to ensure adequate visualization and generally not exceed 1 milliliter per injection site. And finally, the documentation, very important. Details should be clearly stated in the endoscopy report. The tattoo should be photo documented in the endoscopy report, and an institutional protocol for tattooing should be implemented in each center. And finally, Cesare, we will explain us about the surveillance.
So I guess that Sergio also confirmed in the last 10 years, we learned as community of endoscopists to use tattoo for deeply invasive cancer. What we need to learn today is to use a tattoo for identifying post-EMR recurrence. Next slide, Claire. If you are not in the AMC, we have a rate of incomplete resection of about 20%. Next slide. And this means that we have a 15% recurrence after EMR. Next. And even if you don't have the first surveillance, you can have a 4% recurrence rate late. Please don't forget this. You need to check the scar after 1 year. This depends on several factors. I want to pay tribute to Matt Rutter because he showed that the endoscopies and the center play a role. If you are a high volume of EMR, you have a very low recurrence. But if you are a low volume center, this makes the difference. You saw how everything is so good, but you have not at AMC, you will suffer of a much higher rate of recurrence. Next slide. But of course, it depends also on the polyp. This comes from the ESGE EMR guideline by Monica and Alan. And we recommended to consider it a risk factor, a size over 40 millimeter, ileocecal location, prior failed attempt, and the SMSA level 4. Next slide. And this is confirmed by the mythic Australian group showing that over 40 millimeter size, but also intraprocedural bleeding and high-grade dysplasia are risk factor for recurrence. Next slide. The SMSA is quite a complex index that depends on the size, morphology, site, and access of lesion. Next, what is important is the level 4. And next slide. Because this is prognostic. This is prognostic for the complete initial resection that drops from nearly 100% to less than 90%. Please move on, Claire. But this is also, move on, Claire, to all the slide. This is also prognostic for the complication, perforation, bleeding, post-polypectomy syndrome. So if you have a SMSA over 4, you should send to an expert center. I see Evelyn here. Claire, can you move on? Because you pass from a perforation risk of 0 to nearly 9%. Do you use, Evelyn, the SMSA in your practice? Do your trainee refer to you the most difficult polyp for several reasons?
Yeah, that's a good question. I think we should. I think we do, but not officially counting the numbers. But generally, we are called in the room when they are in doubt. The fellows cannot resect larger lesions anyways, but also not all my colleagues are experts in removing colonic lesions. So also they call the expert team to have a look before this decision making.
Yeah, this is very important. As you may see, Evelyn confirmed that the endoscopist plays a role, and you can select in your center a person who is competent in advanced endoscopic section. Next slide, Claire. Move on now to all the animation. Okay, so can we reduce recurrence? Of course, yes. The Australian group, for instance, recommend the hot avulsion technique that was initiated by Greg Haber. Next slide. But this is probably most important modification of our technique, that is this coagulation. Next slide. And you may see that for over 40 millimeter, the recurrence rate drops from 36% to 3%. What amazing data. This really changed your practice. Evelyn, do you perform some thermal ablation after complex EMR? Do you believe in this?
I do believe in this, but I discussed this already many times with Michael as well. I do believe in close inspection, and that's, I think, what this represents. So if there's any doubt about your resection margin, either on the side of it or in the middle, you should perform extra resection. So you could do that either by snaring that extra part or by thermal ablation. So I'm not convinced it is the routine thermal ablation as well as much as it is close inspection and doing anything extra that you think should be needed. Yeah.
This is very important. I mean, close attention is critical. If not, thermal ablation is good. So apparently we are very good in treating recurrence and we are always so happy about it. But let's look at the next slide from the Horsenhaus group. Please go on with the animation. Okay, so please, Claire. Okay, one of the main reasons for which we fail to treat recurrence is because we fail to identify. We cannot recognize the scar, especially in transverse colon or descending colon. And this highlight, next slide, why ESGE recommend a tattoo after EMR when there is a high risk of recurrence. Because if we fail to identify the scar automatically, we don't treat the scar. Next slide. And this is why we should use spot X, because spot X remains visible in the colon for an extremely prolonged time, as you may see in all cases, at least for 3 years. Next slide. When we identify the scar, we need to carefully observe it. And this is the study by the Mayo Clinic by Mike Wallace using NBI plus near focus. And then we go back to Evelien to know if she used and differentiate between low confidence and high confidence diagnosis. And if it is high confidence positive, when there is a nice tube appearance, or of course negative. Next slide. So if you use the NBI plus near focus, I mean the best of your advanced imaging, the sensitivity is 100%. Maybe you don't need a biopsy. Evelien, do you use advanced imaging for detecting recurrence on a scar? Do you biopsy all of them? What's your practice?
I totally agree. You should always use advanced imaging. It's so easy. It's in our new, daily scopes now. So I always look with advanced imaging at a scar, and I also teach the fellows to do so. If I'm confident that it's just local reaction or a normal scar, I don't take biopsies. But of course, in any doubt, I will take biopsy.
Very important message, guys. We have a button. We need to push this button. Next slide. This is the 100% accuracy with the NBI near focus. Next slide. So this is again our recommendation to use tattoo after a EMR at high risk of recurrence. Next. No, just previous one. Okay, this is our last slide. Rodrigo, you want to comment this and then we can close.
Yeah, that's a very important statement because in case of surveillance, the indication for tattooing is in polyps larger than 20 millimeters resected in piecemeal with additional predictors of recurrence. And these additional predictors of recurrence are mainly the SMSA, the size larger than 4 centimeters, the use of thermal ablation for resection, not for completing not as an adjuvant treatment as the study of Michael Burke showed, and also where there are prior attempts filed of resection. So this is an important statement when to use tattooing for surveillance. Go ahead, Cesare.
So guys, oh, okay.
Please close, Claire. Close the presentation. I guess that we can close. No, please go. Okay. No, okay. Claire. Okay.
Yes, Evelien, you said?
Yeah, so I wanted to make, because I look at the questions of the audience, and I think that what might not have been clear is that we inject normal saline into the submucosa as a bleb. And of course you could use also sterile water, but anything normal to just make the bleb. Then change for the tattoo, inject 2 cc to fill the whole needle, and then inject the tattoo. And that has to be only a little, very little bit, so maybe half an ml. Then you can directly go to the next bleb and do that again, only half an ml. So it is important to realize for that reason, you don't need a lot of tattoo, but of course, sometimes you spill a little bit. So that's why there is 5 ml in the tube, which is fine. But you usually only use a little, and then there will be some left in your needle and the length of the needle.
This is very important, Evelien, because my problem was also to over-inject. So you were very convincing, and this message also supported by Sergio video is extremely important. Don't over-inject. So thanks, Evelien, you make this very clear to all of us.
Let me share one or two quick questions of the audience. There is one question from Juan Colan. In case of suspicion of 2 lesions in different parts of the colon with deep invasion or needed to be followed up, is indicated to tattoo it only the distal one or both? Please, Cesare or Evelien.
Well, I think we need the surgeon here as well, but what I probably would do is I would look how far the segments where the lesions are located from each other. But if in any doubt, I would definitely tattoo both, and then probably both distally. But this is one of those very special exceptions that you could even call your surgeon at the moment you run into that, because you can also argue they want one upper and one lower tattoo from above and below above the first lesion and below the second one. But again here, and there was also another exception in the questions that I saw, those are the real exceptions, and you have to put it in capitals in your report what you did, so that the surgeon knows exactly what you did. So if possible, discuss, think very clearly, but make sure anybody that wants to understand can understand your report, what you did.
That's
very important to document that adequately. Very important.
It's very important to write very clear for everyone, because you do the endoscopy, maybe you have not the surgeon and the patients go to the another side, and the endoscopy report should be very clear to everyone that read the report, where is the tattoo, where is the cancer, where is the polyp, or whatever. The only thing that I want to add that is the special side in the transversum column, because in this case, the transversum column could be very floppy, and only in this case may be useful to have 2 tattoo, proximal and distal, because could be very sometimes could happen that it described in the flexure column, it is in the hepatic column, and the opposite. So especially in the very floppy colon transversum, I recommend and to write very well in the report to tattoo cranially and distally, just in the transversus column.
Okay, so thank you very much, guys. It has been a very exciting webinar for a very important and practical topic, and I think we are done with the time. Thank you, Evelien. Thank you, Sergio. Thank you, Cesare, and thank you to all the audience for your interest. And bye bye. See you at the next ESGE webinar.